All right. Good morning, everybody. Switching gears here. So Anita Nemeshek from Dornbecker Children's at OHSU, pediatric transplant. I am switching gears from the sick to the what we do after they're sick. And Diana's going to take it back again. Yeah. So we're going to talk about survivorship and long-term follow-up after bone marrow transplant. I think the team wanted to hear what we do, and I also wanted to do a little bit of a teaching about what we look for in the program. Um, how do I pass this? There you go. So we're going to talk about late effects of pediatric transplant. Think of this as not just pediatric. I think a lot of these things also apply to adults. We're going to talk about manifestations, screening and potential prevention, treatment, and what are the implications in quality of life and well-being for our patients. The good news is that we are treating an increased number of children and adolescents with transplant and cell therapies. There's more indications, especially for non-malignant disorders. So that's about 40% of our business in pediatrics is not cancer anymore. More availability of donors and stem cell sources. You guys know about haplo. So we have a lot of different things that we can do now. We have better disease control. Less people are dying from relapse after transplant than they were before. So we also have more people surviving on the long run. And we have learned to do this better. So less people are also dying from toxicity early in the transplant, and they're surviving early. The survival rate for children and adolescents undergoing transplant is way over 70%. Non-malignancies are closer to 90, and malignancies are still kind of in the 60, 70% range for us. And the challenges are that all those survivors develop chronic health conditions. About 59% of patients in a study have reported at 10 years that they have some chronic health condition of some kind. This was done through the Children's Oncology Group Survivorship team. So that's a big number. 35% of those conditions are reported as life-threatening, something that can actually cause death on the patient. And 5 times more likely if chronic graft-versus-host disease is present. So sometimes we fix the disease and we cause other diseases with what we do. And that's a tough thing to think as people that are trying to help patients. Many challenges to access an intervention with those survivors. We are really good at getting people to us for the treatment of the transplant. And then after that, depending on where the patients are and who they are, they're not able to get long-term follow-up of what they had and what we have done to them. Lack of awareness is one of the reasons why that happens. Either the patient doesn't understand what they need, what the risks are, or the referring doctor you send them back to doesn't know what the risks are, so they don't know what to look for. Some patients never want to come back, so they lost follow-up. They don't answer their phone anymore. They don't want to hear about you ever again, and they stop going to the physicians. They also, because of many reasons, particularly many patients run out of financial funds. All of a sudden lose coverage for what they had. They use all their money for the rest of their life for transplant, and they no longer can afford care. That is a big problem, more than in younger kids, on adolescents that then turn into adults. In the US, kids have access to Social Security type insurance with Medicaid. The minute they turn a certain age, they can lose access to that. They have to apply, and as you know, teenagers are not exactly good at paperwork, so they forget, or they are no longer near their parents, and they are, a lot of the teenagers in the US that are in college or in medical school are sitting there uninsured with essentially emergency care available to them because they have forgotten to do work. So if you get sick and you need complicated care, you can't afford it. They're also at very, very high risk of falling through the cracks of the health system, just because we have made an assumption that the young kids are healthy, and we don't look for things as much. So what causes death after transplant? We tend to focus a lot at the day 100 mortality, and we think infection, GVHD, your disease, but there's a lot of other things. And if you look beyond day 100 post-transplant, you still see that the primary disease is what causes the majority of the mortality. But then that pie chart starts getting a little bit more diverse here, and you start seeing that for younger kids, organ failure is an issue for adults as well. You see secondary malignancies, and you see a lot of this other emerging, which we're just learning about. I think as transplant gets more used, we are learning about things that we are causing with it that we did not know. And in particular, cardiac toxicities and some of the other toxicities are things that we're still learning about. So what influences late effects? It's not just what we do, right? The host is a risk. If they have predisposition to diseases, they can have more late effects. Genetic predisposition, age, gender, lifestyle factors, what they decide to do with their habits can also cause toxicity. The treatment that we use can cause toxicity. Graft versus host disease can cause late effects. And all sorts of things that happen to them during transplant can cause or contribute to the late effects. We also, I have a rule that I teach my students all the time, is that if something was broken before transplant, we're probably going to break it again. So keep an eye on organs that come broken to you. On the thalassemia patients, the liver, for example, lungs, and people have had infections and things like that. So we're going to talk a little bit about each of those things. And one of them that we worry about after transplant is the immune system. We always think, oh, neutropenia in the first 3 months of transplant and thinking about just those infections, but the immune system can take a really long time to recover, particularly in the setting you're doing here with haploidentical. Immune reconstitution is going to be delayed on those patients. For about between 4 and 20% of the late deaths after transplant are actually due to infection. And they look a little different to what we're used to in the hospital or in the early transplant phase. And risks for that are your stem cell source. If you use cord, haploidentical, if you deplete a graft, manipulating it, or if you use serotherapy, in vivo or ex vivo, post-transplant cyclophosphamide can also delay immune reconstitution. And by far, chronic graft versus host disease. Chronic graft versus host disease are patients with common variable immunodeficiency. That's what they are. An immunologist has told me that multiple times. You have created immunodeficiency in your patient, and they will have it for a very long time, and they may never stop having it. You lose protective immunity to vaccines. In the US, it is a little challenging to revaccinate some patients when we lose them out of our system. The way that we give vaccines to children in the US, the vaccines are distributed through the government program, and you're supposed to go to your pediatrician to receive those vaccines. I can't vaccinate children in my hemonc clinic in the state of Oregon. I have to send them to their pediatrician. The good news about that is that I actually have to talk to that physician. And the bad news about that is that I never know if it happened. So it's a little tricky. I can't really just give them the shots like they do on the adult clinic because the vaccines are distributed differently and the patients will get a ridiculous bill for something that they shouldn't have to pay for. So I'm still getting used to that one. So immune reconstitution. We all know that the neutrophils drop at the beginning of transplant, and then as soon as you engraft, they tend to stay high. I tell people to think, okay, your number is normal, but your neutrophils are very dumb, and they still don't work. So don't trust them yet. The first 3 months of transplant. The T cells and the B cells are much longer to recover. As you can see, the T cells drop and then slowly creep up. I would say this graph does not represent haploidentical transplant. That steep curve of going up is not what it looks like on the depleted setting or on the haplo setting. I would say it's probably a little bit less of a slope. And then B cells take really long. Cord, for example, we don't see B cell reconstitution until like 9 to 12 months. If we're looking at the number, and I can assure you the function's not there yet. So patients that leave your site at day 100 from a cord, a haplo, or any sort of serotherapy manipulation, you need to advise them about infection risk. This is I really like this graph, but it is very aspirational, putting bacteria in one place or the other. not quite exactly this way, but at the very beginning, of course, when you have neutropenia, you're at risk for mostly bacteria and fungus, and less for viruses, not zero. As your T cells come in, because you need T cells to be able to for the virus to be able to replicate, that's when you start seeing the viruses. That's why CMV, you tend not to see it at the beginning of the transplant, but you see it more in the middle. And you then see it less as you go along. Aspergillus, at least where we live, it's a all-year risk. Candida tends to be more when you're neutropenic or functionally neutropenic. And PCP is the other one, or PJP is the other one that you actually need to have a graft for you to be at the most risk. Not zero also when you're neutropenic. And then post-transplant EBV and all the other viruses can happen also kind of after engraftment. And particularly if you're in a setting where what I just told you, where your B cell function is really compromised along with your T cell function, EBV loves that environment and can cause a lot of trouble. Respiratory viruses, I don't even know what to tell people anymore. It's an all-year thing now. But hopefully one of these days will turn seasonal again. But you are at risk for that through your entire transplant period. And I'm going to show some data later about how that risk for doing poorly with respiratory viruses is more prolonged. Vaccines. This is an amazing article that I strongly recommend that you print and save. It's called How I Vaccinate, and it's on Blood Journal. It's I think there's a little bit of disagreement about this across the US, but this is Fred Hutchinson Cancer Research Center vaccination recommendations, which were put together by a really good panel of infectious disease doctors. So I really like it. And it, more importantly, it just has, kind of a reminder algorithm of when to vaccinate people based on who they are, If they get chemo, are they at this time post-transplant or this type post-transplant, are they immunosuppressed still or not immunosuppressed still? Are you still giving them IVIG? So it just kind of takes you to the whole panel, because I don't think everybody is ready for vaccines at 6 months post-transplant or day 90 post-transplant. And you need to look at that. And you need to look at your immune reconstitution because you think you're vaccinating people and you're not. So both autologous and allogeneic patients get revaccinated in our programs. We start at day 90 on autologous. We wait to vaccinate children on day 180 because of the immune reconstitution issues. And we want to make sure that they actually latch in. Seasonal influenza vaccine we offer to everybody. So we either give it on day 90, or if you are in the middle of the season, whatever of those applies. We revaccinate for COVID as well. We use the CDC guidelines for immunosuppressed patients, which require that you kind of double them up on everything. And then if they have if they had COVID vaccine and they had a transplant, we revaccinate them, which has been quite a challenge during the vaccine shortage period. And then live virus vaccines, we use the Hutch rule, the 218, which is you have to be more than 2 years out of your transplant to get them. More than 1 year of systemic immunosuppressive therapy. A little bit of steroids is okay. I'm talking the big bang, like on everything. And more than 8 months from the IVIG. And that's because if you vaccinate people when they have IVIG, they don't respond. So 218, remember that rule. Late infections. I'm going to talk about a couple of them. Again, we think bacteria only happens when you're neutropenic, A chronic GVHD patient on a lot of steroid treatment will be at risk for these infections for a lot longer, sometimes for up to 6 months after stopping the immunosuppression. If we could do neutrophil function testing on those patients, those neutrophils are not working well. So they are at really high risk. We have lost patients to strep pneumo in the pediatric setting in my program, and it drives me crazy, but it can happen. Ideally, if you have someone on treatment for chronic GVHD with more than 0.5 per kilo per day of steroids, and you know they're going to be on that for a really prolonged period of time, you want to have them on prophylaxis. In our program, we do it 2 ways. We either take the Bactrim or Septra that we're using for PCP, and we do 1 dose daily, which for some patients it's easier than to add penicillin to the other Bactrim that we're already giving. And then if they cannot tolerate that, some people get really bad stomach ache with Septra and Bactrim, we put them on penicillin like asplenic patients, twice a day prophylaxis. I would say the compliance with penicillin and Septra is lower than the compliance with daily Bactrim in our population. Hypogammaglobulinemia. Now, when I trained for fellowship, everybody got IVIG. We have gotten away from that, except in some cases. Again, I told you about the B cell function and the B cell inability to produce IVIG in chronic GVHD patients. So we look at levels on those patients and we replete on pediatrics. If they have primary immunodeficiencies, they're on that for almost a year post-transplant because they take a really long time to reconstitute. Rituximab in a pediatric setting causes prolonged B cell dysfunction. It's a little different, I think, to the adult lymphoma patients, and we see a lot of patients essentially become permanently agammaglobulinemic from it. And same thing with the CAR T anti-CD19 therapy. We essentially have to keep, if we have done CAR T as a terminal treatment for a patient and not moved to transplant, we have had to put them on prolonged IVIG. And when we have not, we have seen infections on those patients. So we do either IV or sub-Q therapy. I can never tell who wants what. You think, oh, sub-Q is easier. And for some families, it does not work. The kids give them hell and they would rather come to clinic every month to get the IV version because it's a battle at home and they don't want to be hooked up to a thing, you know, the entire time. Insurance is also an issue. Some insurances don't cover the sub-Q, but cover the IV and vice versa. So I can never put a plan in place. We just have to kind of go by the patient. Fungal infections. At risk, again, is chronic GVHD patients at more than 0.5 per kilo per day of steroids, or if there are more than 1 immunosuppressive agent. For us, ruxolitinib, bemoduzole, and ibrutinib all put patients at risk and has been seen on the trial, so we put those patients on antifungal coverage. Invasive fungus is the biggest challenge, mucor, aspergillus. You can still see candida, but it's less frequent. And then we do prophylaxis with an azole drug, which I know in the US, mostly voriconazole or posaconazole. Posaconazole I can only use over 12 years of age. We do not use ITRA a lot in the US. And that's more of a, we just got away from it because there were some resistance issues. And the pricing for Vori in the US is about equivalent. So we don't use it. Viral infections. HSV, VCV, and EBV are a big problem. Late CMV, it's still a risk for some patients, particularly primary immunodeficiencies. So you can have late CMV in these patients, and they need to be monitored for longer. Now, you can't stop at the 3-month point where we usually stop. We prophylax with usually a cyclovir in the pediatric setting because valacyclovir, you have to be, again, over a certain age to be able to do it. For 1 year post-transplant or 6 months after stopping immunosuppression, whichever one of those is the latest. And then we know and have learned from a registry that we were part of all over the US that COVID-19 has a higher mortality and complications for transplant patients way beyond the early transplant period. The reporting that came out that Dr. Sharma published in 21 essentially showed that you, for allogeneic, up to 23 months later, you were at higher risks from 23 months from the transplant, and for autologous, 17 months. So more mortality, more long COVID, more complications of COVID on our patient population than the average patient population, which is the quote that I use when I have to convince insurance companies I have to revaccinate the patients, because some of them don't want to cover it. Iron overload, you can probably give me this lecture because you have a lot of patients. So transfusions, inflammation. So GVHD patients are at risk for iron overload. And it's not just elevated ferritin, it's elevated iron content in their body, I know, for sure. The hemoglobinopathies patients, of course. The clinical relevance of this is, over time, it really can damage a lot of organs that can cause a lot of permanent problems to the patients. And it can also increase risk for infections. Invasive fungus loves iron. It's their favorite food. If you have a patient with high iron, look for Aspergillus because it is growing somewhere in their body if they're immunosuppressed. So very, very dangerous for our patient population. We do screening with serum ferritin. If I see a ferritin elevated, I always ask myself, is it really iron or is it something else? And then I do more studies. We look at pre-transplant, we look at day 100, and we look yearly on our patients if the first ones were abnormal, which they almost always are. For the very high-risk patients, like the hemoglobinopathies, we do liver and cardiac MRIs. We also do this for the bone marrow failure patients, which are also heavily transfused. Not aplastic anemia; those are not as bad. I am old school when it comes to treating this, and if I can, I start with phlebotomy. So, because if you're a big patient, you can do this 10 times better than you're going to comply with your chelating therapy. And getting approval for XJ in the US is a nightmare. We have to ask for a lot of pre-authorizations and things like that. So we don't put everybody on it off the bat. I think it may be a little easier here because you guys have so much thalassemia here. So people, the insurance, the payers and everybody, and people are paying for it themselves. It's a little easier to approve, but that's an expensive drug, and the compliance rate for it is very bad. So when they come in for their labs and their checkup, we just take 5 per kilo, as close as every 4 weeks. Sometimes we space it out. We monitor the hemoglobin and we monitor the ferritin. And it takes, for someone with a ferritin between 15,000 to 3,000, it takes about a year or two to get through it. But that's about how long it takes with the XJ2 for us. Probably because they're not taking it, but it's just worked for us really well. Late effects of kidneys are a big problem in our patient population, and in pediatrics, a very ignored problem in our population. We don't think about looking at high blood pressure in kids because you're in a room with a kid and they're screaming and kicking, and you never know if the blood pressure is normal or not. And then I think we just don't look at it as closely as in the adult world. So it's really easy to miss hypertension on pediatric patients. It's a very common complication. And as you can imagine, it's because we do a lot of things to them. Calcineurin inhibitors, steroids, multiple nephrotoxic medications. And a lot of patients have come to us already with a history of acute kidney injury that has probably been missed in the pediatric setting. In adults, I see that on the notes a lot more frequently than I see it on kids. But then when you look back at the records, kids have had AKI before coming to us. Sickle cell disease, very common for people to have had kidney injury before they came to us. So we screen for it. Pre-transplant, we get a really good baseline to know where they're at if we know that we have an at-risk patient, and then we monitor during the transplant. We monitor because you can manifest this in many ways. One is with chronic kidney disease. you have these people that essentially double their creatinine after transplant and they never go back to normal. And then they slowly creep up. When I look at survivorship for our program, people that are now in their 30s that had transplants with us when they were teens, many of them are kidney patients. And at that point, there wasn't a survivorship program in our program, so nobody knew about it. So we spent, a medical student, God bless his soul, spent a lot of time digging into this information for me. He is actually one of our former transplant patients who is now a pediatric hemonc fellow in Atlanta. So he had a huge interest on late effects, and he's actually doing his fellowship project in Atlanta right now, also on survivorship. So it was good because he knew what he was looking for. So he was really, really handy. Nephrotic syndrome, more common than I would like. It usually comes tied with graft versus host disease, and some people argue that it may be a manifestation of graft versus host disease. It is really easy to miss until people get sick, and then you bonk yourself in the head because you didn't see it. We screen patients, and then risk factors. If you've had BK virus activation, your patient risk for chronic kidney injury is about 3 to 4-fold of that of someone that hasn't had BK. Graft versus host, you don't have to have full-blown hemorrhagic cystitis for that risk to exist. Graft versus host disease, as I mentioned, acute kidney injury, and if you've had radiation, even if they have shielded your kidneys during the treatment, you're at risk for kidney disease. What we do is that we monitor blood pressures at every visit. We look at the kidney function. We also do urine dips at particular time points in our patients in the pediatric setting, looking for a microalbuminuria. And this comes from a paper from Sangeeta Hingorani, who's probably one of the best kidney transplant doctors that I know, that has done her entire career research on that. We manage hypertension. We are pretty aggressive with management of hypertension in our program, probably more than most pediatric places I know. But that's because we have a really good kidney team that has taught us how to do it, and they engage with our patients. So when I have an at-risk patient that I diagnose with hypertension, I put a renal consult, and my kidney doctors actually come to my clinic to see the patient. The patient doesn't have to go to another appointment, and I'm really spoiled with that. We refer them if they 1 times 5-fold their creatinine really early. And the reason I do that is because I do not want to hear my nephrologist telling me that we called him too late and we should have called him 2 weeks ago, which they do all the time. But they're really, really, really good. And our patients love it because managing, anybody can start blood pressure medicines. We are not all very good at weaning people on blood pressure medicines, and the kidney doctors do that beautifully. So it's just been a great program for us. So you'll hear a lot of, I've tried to establish multidisciplinary clinics inside of the setting of my space, because many of our patients drive really long and I don't want them bouncing around. So we've just played nice, and we have the space. It's actually harder to get them into the regular clinics. And if the doctor can come to the patient, it works better for us. So we do that with kidney doctors, pulmonary, endocrinology, and it's worked really well. Pulmonary late effects. I'm going to talk very little about this because I think Richard is going to do that this afternoon too. Super easy to miss. What patients will do is that they're going to have shortness of breath and exercise intolerance, which in a kid is impossible to measure because they are very active, so they never look sick to us, right? Wheezing and crackles come later. Hypoxia comes way later. Risk factors, busulfan. Dr. Sanders used to tell me that busulfan is liquid radiation, and it is, especially in children. Total body radiation can cause damage to the lungs, even if you shield the lungs during TBI. Graft versus host disease, by far a lot. And if your patient has had a respiratory infection during the early transplant period, keep looking for problems later, because post-infectious pneumonitis is very common in our patient population, and we miss it a lot. Screening, history. Your lung exam sometimes helps, and kids almost never. Pulse oximetry at every visit and look at trends. Kids with bronchiolitis obliterans and with problems post-transplant, they don't go from here to here. They just slowly wiggle down, and you can see it. You can see it when you look back, unless you're paying attention to it. Spirometry with diffuse lung carbon monoxide capacity is something we do on our patients pre-transplant at 3 months, at 6 months, at 9 months, and at 12 months in the pediatric setting. Adults don't do that. You do you good? Okay. It's really easy to miss, and I do that on high risk patients. I will tell you, it's easy for us to miss the 6 and the 9 month on our remote patients because many of them don't want to come back. And honestly, if you do PFTs in a bad lab for a kid, you might as well not do them because you can interpret PFTs done in 2 places with different techniques. A 6-minute walk test is a very cheap pulmonary function test where you make person walk briskly. They're not, window shopping, walking. They're walking, and we give them a chronometer and we send them down the hallway. Pulmonary does that for us, but some patients that are not having pulmonary tests, I have them do that at home. And they can, in their pediatrician office, the pulse oximeter be measured. You will see people that don't look sick, like they get tired just from that. So, and then, if you really have a high index of suspicion, the only way that you can look at this disease is with high resolution chest CT. Of course, you can do biopsies, but nobody wants to touch anybody with a biopsy, and it doesn't really add to the diagnostics. What do we do? I scare the living life out of my patients about smoking, vaping, and tobacco products. And in my town, also smoking anything else, because we have legal cannabis. It's smoke. The problem is smoke. Referral to pulmonary if more than 15% decrease in pulmonary function symptoms. This is another team of mine that if I call them late, they get so angry at us because the patients are really sick. Cardiac late effects, very unrecognized in children. Congestive heart failure, coronary artery disease way earlier than you were supposed to get it. It's something that we run into. And risk factors for that are pre-transplant exposure. So anthracycline exposures on our leukemia patients cause a lot of harm. And I can see that on my pre-transplant evaluation for the echo. Cyclophosphamide also can do it. Total body radiation can do it. Graft versus host disease, mostly as it pertains to steroid exposure, can cause hypertrophic cardiomyopathy. We take a history, we check the heart. We are pretty good about checking echocardiograms, particularly if there's high risk. We use Children's Oncology Guidelines for cardiotoxicity. So there's these tables that tell you, depending on what treatment you get, how often you have to have the screening done, and we just follow those. Interventions, we are pretty big about healthy lifestyle promotion in our program. I actually teach exercises to my patients, and we always, they laugh at me when some of my teenagers go, every time I come here, we talk about the gym. I like it because I'm always asking people, are you exercising? What do you do for fun? Are you moving? Tell me what movement is. And I'm actually in a project right now with some of our population health scientists to try to formalize that process for our post-transplant patients, which in pediatrics is not done very, very frequently. Prevention of obesity, a huge problem in our country. We have published data from a late effects, very large study in the U.S. for pediatrics, where we have shown that we have about 35% of our pediatric population arrive to us with morbid obesity in the US before we touch them with anything. And then you give them all this stuff and it's a disaster. So a lot of type 2 diabetes before and after transplant. We have a lot of people with metabolic syndrome. So we refer to cardiology if we see abnormal echo and EKG symptoms pretty early in the process. Talking about metabolic syndrome, again, central obesity, hypertension, high blood sugar, high hyperlipidemia. When you have this, you will be at increased risk for cardiovascular and cerebrovascular disease. And a kid with metabolic syndrome before the age of 16 dies before the age of 50. And that is a known statistic in the US. And I can't believe that I have to have that statistic in the US. So it's pretty bad. Risk factors, pre-transplant exposures, again, TBI, steroids, and by far lifestyle choices, which is something we can modify, right? So we screen with height and weight, blood pressure at every visit. Our nutritionist, I call her the clinic helicopter. She's looking at all the anthropometrics of our patients, and she refers herself for consult. She just shows up in the rooms when we're there. We're really blessed we have a nutritionist in our clinic. That is not something a lot of people do. We check lipid profiles, and I check them before the transplant. We check them at 3 months. If those are normal, I don't check until a year. If they're abnormal, we start monitoring. And I have put patients on cholesterol lowering agents, little kids, since very young. We check fasting blood sugars. We used to check insulin levels, but they take so long that they're good for nothing. So like 3 weeks later, I'll get a result and I don't know what to do with that. And again, healthy lifestyle. In the US, there is actually now for pediatrics an indication for use of semaglutide on people that are high risk. A transplant patient with metabolic syndrome would probably get that drug approved in the US. Really expensive. I think without insurance is like $1,000 a month or something like that. For the metformin in kids is a disaster. Their GI tract, I don't even try. Yeah, they take it and they just get so sick. This doesn't seem to be causing that problem. I have prescribed semaglutide to 2 patients in our clinic in the past year. Yeah. So endocrine late effects, this is more for the kids and for the adults. Growth hormone deficiency, it's still an issue. If you are less than 10 before we give you particularly radiation, mostly cranial. I've actually not had patients develop growth hormone deficiency solely from total body radiation, the way that we give it. If you radiate the brain for leukemias, you are going to get it. There's no question. Hypothyroidism, if you're younger, likely, but you can also get it without. It's not here, but busulfan can cause hypothyroidism as well. And radiation, again, the same problem. Hypogonadism is a problem more in females than in males. More in near pubertal to post-pubertal patients. For good or bad, some prepubertal patients do not have problems, even when we use all the things that could cause it. I counsel teenager females that get busulfan that their chances of sterility are nearly 100%. So we have things that we do to help them. Infertility is a big problem on our patients. Malformations, if they have pregnancies, are also very common. And then low adrenaline, hypoadrenalism, mostly for prolonged steroids patients or patients that have had cranial radiation. So we screen baseline before transplant, we screen at 3 months, and then we screen at a year and yearly after that. We are very adamant at Tanner staging our patients before they come in, particularly because of the survivorship clinic I'm going to explain. And puberty in the US keeps lowering in age, so we're starting the screens now when the patients are 10 for pubertal development. Cortisol in the morning is something that I let my endocrine people do because they can do more testing after that. And we, again, engage endocrine pretty early. So if screening becomes abnormal, I call in the endocrine person to see our patient. Growth failure, we do try to use growth hormone therapy when possible. That is really hard to get approved in the US. That I let endocrinology manage for whoever needs it. Not everybody needs growth hormone therapy. It is quite a commitment for the families financially and compliance-wise because it's an injection. And there was a big myth for many years that growth hormone could give you relapse. There has been zero scientific evidence of that. So we do not go there. What there is evidence is, and endocrine would scream at us if we send the patient, if you're on steroids, do not put someone on growth hormone. You actually increase the risk for fractures on their bones because you're stressing a really sick environment, and the growth hormone actually doesn't work very well. And they get a lot of pain when they get the injections. Ovarian failure, I showed you how common that is, and how much more we see it. If you're post-pubertal, we're talking, really high numbers in the patients. If you're prepubertal, some of them escape the infertility and the ovarian failure. Busulfan, this is what chemotherapy with busulfan looks for ovarian failure. So I really try to advise people before they come in. And that may be one of the #1 reasons why sickle cell disease patients decline a transplant in the US, or gene therapy, because with gene therapy, you also condition with busulfan for now. So there's a great opportunity there to try to explore some other drug. I would say that this is a point of a lot of debate in the US, because the sickle cell disease population is also our Black population in the US, and they are convinced that nobody's wanting to change this because of racism. So it's been a big point of discussions when we go to patient conferences and the patients are there. They get up on the microphone and I start screaming at the doctor. It's very difficult to watch. So male survivors can also have reproductive issues. Busulfan, cyclophosphamide, and TBI destroy germ cells. That has been shown in the lab, that has been shown in animal models and in humans. They can have low testosterone. Clinical presentations are delayed puberty. They can also have precocious puberty because their axis gets flipped. And they can have azoospermia or oligospermia and potential infertility. There has not been any study showing congenital malformations of in children of male transplant recipients. So that there doesn't seem to be a correlation there with that is there for females. What do we do about this? We counsel the patient. This is actually a really good graph. If you want to kind of remember who recovers function and who doesn't, this is really old and nothing else has been published after this paper in '96. So again, busulfan really makes a huge difference. You can see some sterility also on TBI, but that was more when we were giving really high doses and not at the 12 gray that we have settled with in the US. Females can have more spontaneous abortions, and again, the males don't have increased risk for congenital malformations. We are pretty aggressive with reproductive counseling in our program. We do counseling pre-treatment. It is now considered a standard of care for children treatment with cancer. We work with providers in the reproductive endocrinology team. We try to work with the patients to see if we can suppress ovarian function during transplant. You can do that with Lupron. Some patients don't tolerate it at all, and they get really bad hot flushes, and they don't want to do it again. And then we try when we can to put tissue or sample away. For boys, super easy. If they're post-pubertal, they can do sperm donation. For prepubertal males or females, we are doing tissue harvesting, but that sometimes it's a little tricky with the timing of the transplant, depending on when we meet the patient. I'm in continuous conversation with my oncology team for them to start this process before they send the patient to me and not wait for us to do it. It's a work in progress, but we're getting there. We actually have a program where we cover part of the cost of this for patients for up to 2 years, which is great. And it's a foundation that's doing it for us. Insurance companies do not cover this. Bad bones are very common in our patients. The older you are, if you're a female, it's not here, but if you're obese, if you are Caucasian or Asian background, you tend to have more problems with osteoporosis and osteopenia. The main main risk here. It's really treatment with prolonged steroids. And we, again, encourage physical activity. We put everybody on vitamin D and calcium supplementation. We live in a very dark state, and everybody's vitamin D deficient where we live, particularly in the winter. We tell people to avoid smoking, alcohol, and caffeine as much as possible. And then bisphosphonates are used. We really don't use that a lot in pediatrics. We used to, and there was one study in peds that essentially showed there was no difference. So it's a little different to the osteoporosis of adults, and it can regenerate. This, though, is a big problem for us. It's a disabling complication after transplant, mostly seen on prolonged use to steroids, but also patients with sickle cell disease come to us already with beginnings of a vascular necrosis, if not advanced. And this is a source of a lot of disability. The knees are the number one culprit, followed by the hips and shoulders. That fellow, that's a hemonc doctor now, the hemonc fellow, has had the two shoulders, the two hips, and the two knees replaced. Yes, because he had really bad GVHD. It can present really late after transplant. Like your patient can look like, oh, they're out of the woods, and then they come back complaining of pain to a physician or to your survival clinic. We take history, we do good exams, and then really MRI is how you find it. And you send people to the orthopedist as soon as possible. A young adolescent or child with this will eventually need more than one replacement of their joints. And who does that for you orthopedic wise is like the number one thing that I look at, because not everybody can do the surgery properly on a kid. Secondary malignancies are a problem. The risk goes up every year you survive. There's not a point that you abandon the risk. It keeps going up every single year. We have noticed that the younger the patient, the older the patient, there's like peaks of excess secondary malignancies compared to controls for your age. So the older you are, the higher the risk for that differential, but you can see it at any time. And what we usually see is MDS and leukemia in kids. Usually within the first 3 years post-transplant, but not always, and sometimes we have been surprised. Lymphoproliferative disorder, it's common when you have had GVHD or immunodeficiency patients tend to have it more. I would say in your setting too, because of the haplo setting and what you use for the conditioning, and you probably have risk for that reason as well. And then solid tumors are usually related to radiation and to genetic susceptibility. We have a lot of patients with that. Skin is probably a number one thing. So when patients are, when they keep visiting us and they hit the 5-year mark of survivorship, I refer everybody for a mole scan to the dermatologist. So they essentially take a picture of them head to toe, and they map their moles. It's like going to a dentist and getting your dental films, because that's the only way you're going to be able to follow this up over time. We have diagnosed 3 patients, kids with skin cancer in our clinic at Dornbecker for the time that I've been there, which is, I think a lot. And they start like tiny little, particularly TBI kids, they will just develop this tiny mole that to me looks normal because we all have them. And then, but they didn't have it before. And those are the ones you need to watch because they do change. Eyes are a problem in our kids. Cataracts are a huge problem. They tend to be behind the lens and they don't give problem at the beginning, but they need to be followed because they progress. And we have had patients getting cataract surgery when they're in their early 20s, as opposed to, 50 or 60 when they usually do. Almost everybody ends up needing glasses. And then if you have GVHD, it's a big issue. We, again, really blessed. We have a ridiculous pediatric ophthalmology team, and they see our patients during survivorship. Your teeth are a mess when you are a kid and you have a transplant, especially if we radiate you. If you were an infant, I tell people to be ready for some heavy bills when the kid is older, because the teeth production gets interrupted, and what comes out of that first batch of teeth does not look normal. and they need a lot of work. We have our dental team see our patients pre-transplant. They also come to our inpatient unit once a week to evaluate patients with mucositis, because the pediatric dental team does teaching with our patients. So we have a great relationship where they just come to us. And we also try to get as much dental work as possible on our kids before they come to us, because that also has been related with bacteremia and bad outcomes in transplant. Everybody complains about dry mouth after a transplant, with or without GVHD, for the rest of their life. I've never seen someone not complain. And oral GVHD, which is something that we have to really look for in pediatrics, because they don't complain until they're really sore. We try to keep them seeing the dentist. Psychosocial complications, big problem. And we are just learning about this, because patient-related outcomes in pediatrics did not have really good validated tools until like the last decade. So we have a lot of missing data here. What we're learning is that people that had transplants when they were kids, even after many, many years, are having trouble finding employment, are having trouble going to school, or are not working because of health-related issues. And a pretty good number, we're talking about a third of those patients, and that's a lot. This is really complicated, right? You also have, for pediatricians in the room, vulnerable child syndrome, right? So you're going to be very overprotected after something like this by your family. So your psychosocial development is going to be behind. So we are really aggressive with that and trying to get the pediatrician engaged and early intervention and engaging the schools to make sure that our kids don't get treated different because they had a transplant, chronic GVHD can cause issues. Lower performance scores in exams happen. People, when we do neuropsychology testing for people, particularly that had cranial radiation, their processing is delayed for mathematics and for reading and for logic. The majority of people with a IQ in the middle of the normogram or advanced, you just drop a couple points and you don't see it. But when you were already here in the normogram, we tip you off. So getting that baseline exam and knowing that there are some people that you're going to have to be more aggressive with, it's really important. We have a school inside of our inpatient unit, so the teachers do that assessment with us before they come in. Again, the physical functioning is also a problem, and emotional problems. People and their caregivers report more depression, more anxiety, post-traumatic stress disorder. I have a kid that comes to Survivorship clinic every year, and he throws up in the parking lot before he comes in. So every year, the mom comes in with a barf bag and puts it in. And it's been going on for really long. A lot of them need special education. A lot of them depend on financial support for disability, or have difficulty obtaining health insurance because of predisposing conditions. That has gotten better in the US after we changed our insurance system, but it still happens with private insurance. I'm going to show you some places where you can go hunt for more information. This is a Be the Match resource for providers. These links have a wealth of information for you to go through. I'll send the slides to you so that you can click on the link and get them. And same with this, resources for the actual patients. When you go into this website, there's going to be on the right-hand side, every language you can possibly imagine, you can click and it will translate the material for you. And if you can't find your language there, you call their office and they do it for you. And you don't need to be part of the NMDP for that. It's a public. And then this is what we do. This is our survivorship clinic. I decided that I'm not going to do this by myself. Survivorship is survivorship, and it needs a multidisciplinary team. So we have a team that does malignancies, non-malignancies, transplant, no transplant. And we see patients from age 0 to age 40 in that clinic. They can be seen virtually or in person. What we do for transplant is that the 6th and the 6th and the 9th can be virtual. The 12th month, I want in person. Ideally, the yearly, we want in person. Sometimes we do virtual if the patient lives really far, and we do it with a pediatrician. So we send them a summary of what we want and need. And either the patient, depending on the state, sits in the pediatrician's office and I see them and I can bill, or sits in their house, depending on the state, and I can bill. And then once they get to that 5-year mark, we see them every other year till year 10. And then after year 10, they're invited to come back every 5 years to that clinic. But the whole point of this is to summarize the care of the patient and hand it over to the referring general provider that's taking care of that patient out there and to the family. So they have those summaries with them and they have access to them. So many challenges. If you follow them up, you can deal with many of them. Working with those referring providers is crucial. We can't do this by ourselves. We're not a primary care setting. And then transitioning your patients to normal, it should be part of the treatment of a patient. Many of the things we see emotionally are because we forget to do that part. And I think it's really hard for the families to do on their own. So I have put some questions here, but we don't really have much time. So if you're 20 and you had a transplant 10 years after an unrelated donor for AML, and you got busulfan and Cytoxan, the patient is now asking you if you think that they're going to be able to have kids. So it's a male, 20, had the transplant when he was 10, busulfan. So what's the answer? We have no idea, but it's not 100% and not 0. Question 2. What are true about growth failure? It's multifactorial. Growth hormone therapy is beneficial to all patients. Only people that had radiation are at risk, and growth hormone increases relapse risk. Yay. And last one, post-transplant patients are at risk for. All right, thank you.